Hello and welcome, fellow student doctors. Today, we will discuss leukopenia. Leuko refers to white and penia means poverty. So leukopenia means a poverty or lack of white blood cells. There are many reasons why patients may have a low white blood cell count. The term leukopenia does not differentiate which white blood cells are deficient. Are we talking granulocytopenia, monocytopenia, or lymphopenia, or subcategories within each? We are in for a fun discussion. Let's go ahead and get started. To prepare you for test day, you'll be able to 1. Define myelosuppression, pancytopenia, myelophthisis, and leukopenia. 2. Describe from most to least common the normal white blood cell distribution. And 3. List causes of leukopenia. Let's start by defining pancytopenia. Pan means all. Think COVID-19 pandemic, an infectious outbreak all around the world. Cyto means cell, and penia means poverty. So there is a poverty of all 3 cell lines produced by the bone marrow. This includes thrombocytopenia, or a low platelet count, anemia, or a low red blood cell count, and leukopenia, or a low white blood cell count. Leukopenia may result from deficiencies in one or more types of white blood cells. Granulocytopenia refers to a low granulocyte count from neutropenia, eosinopenia, and/or basopenia, all granulocytes. To recall the granulocytes, use the Granny-Phil mnemonic, as the key granulocytes end in phil, such as neutrophil, eosinophil, and basophil. Notably, mast cells are also a type of granulocyte, but are found predominantly in the tissues, where they release histamine to regulate allergic reactions and other pathways, and are not measured in the blood. Hence, when we think of granulocytes, we usually think of neutrophils, eosinophils, and basophils because these are routinely measured in the blood. Next, monocytopenia refers to a low monocyte count, and lymphopenia means a low count of lymphocytes, B cells, T cells, and natural killer cells. Deficiencies in any of these white blood cell lines can result in leukopenia. While there are many etiologies of leukopenia, anything that causes myelosuppression can lead to pancytopenia. Myelo refers to bone marrow. With all of these cell lines originating from the bone marrow, any cause of myelosuppression can result in pancytopenia. In terms of leukopenia, myelosuppression mainly results in granulocytopenia and monocytopenia. In reference to lymphocytes, T cells leave the bone marrow to mature in the thymus early in development and are stored within lymph tissues. B cells arise in the bone marrow and mature in the bone marrow throughout life, with the majority being stored in lymph tissues such as the spleen and lymph nodes. Let's apply some numerical values to leukopenia, which is defined as a white blood cell count less than 4,500 white blood cells per cubic millimeter of blood, whereas a normal white blood cell count is between 4,500 to 11,000 white blood cells per cubic millimeter of blood. I want to note that on test day you will be given these values. I am simply giving them to you here so we can have an informed discussion. Looking at the diagram, all of these cells originate from the bone marrow. Notably, the cells highlighted in red indicate those routinely found and measured in the blood, hence the imaginary blood vessel that is outlined here in red. Adding some demarcations, let's discuss normal and deficient blood levels of these cells. A normal red blood cell count varies between men and women, but is generally between 12 to 17.5 grams per deciliter. A low red blood cell count varies between men and women, but is generally less than 12 to 13.5 grams per deciliter and is called anemia. A normal reticulocyte count is between 0.5 and 1.5%. Quick question. Where is the cytokine produced that drives normal red blood cell production? Erythropoietin is produced by the interstitial cells surrounding the peritubular capillaries in the kidneys. What kind of pathway does it signal by? Erythropoietin is a cytokine, so think JAK-STAT signaling. Nice work, student doctor. A normal platelet count is between 150 to 400,000 per microliter of blood. 1 cubic millimeter is equal to 1 microliter, while less than 150,000 marks deficiency, called thrombocytopenia. In terms of white blood cells, normally eosinophils compose 1 to 3% of the normal white blood cell count, which means that eosinophils make up 1 to 3% of 4,500 to 11,000 white blood cells per cubic millimeter or microliter of blood, with deficiency being marked by less than 1%. Basophils normally only occupy 0 to 0.75% of that fraction, with deficiency being almost undetectable. Neutrophils make up the majority of the white blood cell fraction, composing 54 to 62% of it, with deficiency being marked by less than 51%. Neutrophilic bands compose 3 to 5% of the white blood cell count. Importantly, neutropenia is usually defined by the absolute neutrophil count, ANC, being less than 1,500 per cubic millimeter of blood. This number configures neutrophilic bands and mature segmented neutrophils into one number. As you can see, monocytes have a distinct development from granulocytes and are not a type of granulocyte. Students frequently mess this up, so let me give you a way to think about it. Granulocytes have granules in them, hence the name. They use these granules to spill them onto parasites in the case of eosinophils, to release during allergic reactions in the case of basophils, and while fighting bacterial infection in reference to neutrophils. These granules destroy things. Monocytes become macrophages in the tissues and are not granulocytes because they don't want to immediately destroy things with granules. They want to phagocytose and present antigens via MHC complexes to other cells to link innate and adaptive immune systems. Overall, monocytes compose 3 to 7% of white blood cells and are deficient when present below 3%. Lastly, lymphocytes, B, T, and natural killer cells compose 25 to 33% of the normal white blood cell count, with deficiency being marked by less than 25%. To recall the normal white blood cell distribution, use the mnemonic, "Never let monkeys eat bananas." In order from highest to lowest percent concentration, neutrophils never, lymphocytes let, monocytes monkeys, eosinophils eat, basophils bananas. Never let monkeys eat bananas, and never forget the normal white blood cell count distribution. Leukopenia will be on your exam multiple times. So, broadly grouping etiologies to form a differential diagnosis in your mind is very important. There are drug causes, such as from chemotherapy agents, clozapine, an antipsychotic drug, and propylthiouracil and methimazole, drugs used in the treatment of hyperthyroidism. Infectious causes can come from viruses, bacteria, fungi, and parasites. Neoplastic causes, both cancerous and non-cancerous. Bone marrow causes, such as aplastic anemia and irradiation, which may be performed prior to bone marrow transplantation. And lastly, immune disorders, both inherited and autoimmune, that can cause leukopenia. For the rest of this lecture, I will give you some high-yield examples for each category. Glucocorticoids, one class of steroids, are immunosuppressants that alter levels of white blood cells in the blood. Let's base our discussion in the diagram shown. A cell membrane outlined in a ring of yellow phospholipids, a cytoplasm, and a purple nucleus. Glucocorticoids exert anti-inflammatory actions to multiple pathways. The first is the arachidonic acid pathway, which occurs by PLA2, phospholipase A2, converting cell membrane lipids into arachidonic acid. Subsequently, lipoxygenase and cyclooxygenase convert arachidonic acids into prostaglandins, leukotrienes, and thromboxanes that mediate the inflammatory response. The second pathway involves NF-kappa B, a transcription factor that promotes expression of genes involved in the inflammatory pathway. So, how do glucocorticoids, a type of steroid, affect these pathways? Well, the glucocorticoid receptor is located intracellularly. This means that the steroid molecule must pass across the cell membrane to access its receptor, which it can do because steroids are lipid-soluble cholesterol molecules that can pass through the lipid-soluble cell membrane composed of phospholipids. Once inside, the glucocorticoid receptor complex inhibits phospholipase A2. This is the non-genomic or non-DNA effect of steroids and accounts for their immediate effect on pain and inflammation, as this complex can directly inhibit phospholipase A2 in the arachidonic acid pathway. The more long-term effect of glucocorticoids on inflammation centers around its genomic or DNA effect, as this complex can enter the nuclei of cells to inhibit the NF-kappa B promoted pathway of inflammation. Additionally, this complex promotes the expression of anti-inflammatory genes that produces anti-inflammatory proteins such as interleukin-10. Now, let's discuss what happens when glucocorticoids enter certain white blood cells, starting with neutrophils. You must understand that there is a marginated pool of neutrophils ready at a moment's notice. These stored neutrophils hang like bats in a cave from blood vessels, especially blood vessels in the lungs via selectin proteins. Interestingly, glucocorticoids downregulate selectin proteins and other cellular adhesion molecules, releasing these stored, marginated neutrophils into the circulation, the circulating pool of demarginated neutrophils. The demarginated neutrophil pool are the neutrophils in circulation that are measured with a blood draw. The release of marginated neutrophils actually causes neutrophilia and an overall increase in the white blood cell count, a leukocytosis. What? Johnny, you told me this was a lecture on leukopenia, or low white blood cell counts, and now you're telling me glucocorticoids cause neutrophilia and an overall increase in the white blood cell count, resulting in a leukocytosis? This is what makes steroids, glucocorticoids, and their physiology so high yield. Glucocorticoids cause eosinopenia, monocytopenia, and lymphopenia. But glucocorticoids actually cause neutrophilia and an increase in the overall white blood cell count because neutrophils are the most abundant white blood cell in the blood. Remember the never let monkeys eat bananas mnemonic? This effect on neutrophils is still an anti-inflammatory action by glucocorticoids because neutrophils need selectin proteins and other cellular adhesion molecules to attach to blood vessels throughout the body to physically enter into sites of inflammation. With selectin proteins and other cellular adhesion molecules downregulated by glucocorticoids, neutrophils cannot enter into sites of inflammation. The neutrophils are trapped within the blood vessels. So, on test day, when you see a patient with a neutrophilia on their white blood cell counts, you will immediately start thinking of bacterial infections and your mind will go down that route. Make sure you look at their drug list. If the patient is on a glucocorticoid, they probably have neutrophilia due to the downregulation of cellular adhesion molecules and selectins. I promise you that will get you a point or lose you a point on test day. That is up to you. Make sure you know this fact before you sit down for that exam. In terms of eosinophils, they become sequestered in lymph nodes, as shown here, while also undergoing apoptosis, resulting in eosinopenia. Think about it. Just like glucocorticoids interfered with neutrophil adhesion molecules, the selectin protein above, so too do glucocorticoids affect eosinophil attachment proteins, ultimately sequestering eosinophils within the lymph nodes, reducing the inflammatory response. Lastly, glucocorticoids result in apoptosis of lymphocytes, shown here, as well as monocytes, not shown, all of which decrease the inflammatory response. Let's group infectious etiologies into 4 categories, starting with a high-yield cause of eosinopenia. I want you to diagnose this patient. Let me give you the details. The patient has been traveling and presents with a stepwise fever that rises and falls, rose-colored macules on their skin, as shown by the arrows, gastroenteritis, eosinopenia, and has pulse temperature dissociation, meaning their temperature is high, but they have a relative bradycardia. What is the diagnosis, student doctor? This patient is infected with Salmonella typhi, a gram-negative rod that causes typhoid fever. Enteric fever, typhoid fever, same thing, is associated with eosinopenia, a good clue-in for the diagnosis on test day. The classic cause of lymphopenia is HIV, which infects and depletes CD4 positive T cells. In terms of monocytopenia, EBV, the Epstein-Barr virus, causes mononucleosis, leading to hepatosplenomegaly. This image should show you why people who get mononucleosis should avoid contact sports due to the risk of splenic rupture. Just look how big that spleen is. Importantly, EBV can lead to monocytopenia or monocytosis. Before moving on, I want to clear up some terminology. Compare the monocytes pictured here to the lymphocyte pictured under the lymphopenia column. You can see that these cell types have one single nucleus. That is, they are called mononuclear cells. This shared characteristic actually gave mononucleosis its name, but it is a bit misleading because mononucleosis makes you think that monocytes are the key cell in that disorder. They are not. Mononucleosis actually refers to a proliferation of mononuclear cells called reactive lymphocytes, which is just a CD8 positive T cell becoming angry. It's unraveling its nucleus, revealing all its genes necessary to fighting off the Epstein-Barr virus infection. And so, pathologists originally thought that mononuclear cell was a monocyte, so they named the disorder mononucleosis, but here that mononuclear cell was actually a reactive CD8 positive T cell ready to fight off the viral infection. And so, that is where mononucleosis gets its name, for the reactive CD8 positive T cell, not the monocytes, but overall, it is important to know that Epstein-Barr virus causes mononucleosis, which can lead to monocytopenia or monocytosis. Rather than discussing a cause of neutropenia, let me explain a high-yield association, especially when a neutropenic patient has an absolute neutrophil count, ANC, less than 500 per cubic millimeter of blood. Neutrophils are key in fighting bacterial infections, especially those caused by Pseudomonas, which produces pyocyanin, a blue-green pigment. A patient with severe neutropenia can classically develop a Pseudomonas infection presenting with ecthyma gangrenosum. This is why neutropenic patients have anti-pseudomonal antibiotic coverage, Make sure you know all the antibiotics that cover Pseudomonas before going in for test day. Lastly, sepsis from any cause can lead to leukopenia or leukocytosis. Those developing leukopenia have a worse prognosis, which makes sense as the immune system needs to overcome the infectious cause of their sepsis. To discuss neoplastic etiologies of leukopenia, I want to base our discussion in normal granulocyte development and a resultant cancer from abnormal granulocyte development. Looking at the diagram, know that there is a common myeloid progenitor cell that gives rise to red blood cells if stimulated by the cytokine erythropoietin and platelets if stimulated by the cytokine thrombopoietin. If acted upon by other cytokines, such as granulocyte colony stimulating factor, that common myeloid progenitor can differentiate into a myeloblast that gives rise to all the granulocytes. Remember the mnemonic Granny Phil, Granny for granulocytes and Phil because of their common endings. We are talking about basophil, eosinophil, and neutrophil development here. That myeloblast can become a basophil promyelocyte, an eosinophil promyelocyte, or a neutrophil promyelocyte. Development continues from each of those cell lines to myelocytes, to metamyelocytes, and to bands. Listen closely now. While most of these cells develop in the bone marrow to their mature forms, their development can be rushed to the point that promyelocytes, myelocytes, metamyelocytes, and bands can be prematurely pushed into the bloodstream. That's what a left shift means in the setting of infections. Neutrophilic bands and other earlier developmental types of neutrophils are produced so quickly that these immature forms are found in the blood to an above average value. That's not really normal because it's usually induced by some other condition, like infection. Really, the normal is that a few immature forms like bands can make their way into the bloodstream, but the majority of cells are released from the bone marrow into the bloodstream in their mature forms of basophils, eosinophils, and neutrophils. Resetting our diagram, let's discuss CML, chronic myelogenous leukemia. Normal granulocyte development occurs due to normal stimuli from cytokines. Chronic myelogenous leukemia causes pancytopenia because it is a cancer that is not regulated by normal stimuli from cytokines. Rather, the Philadelphia chromosome drives granulocyte development. The Philadelphia chromosome involves a translocation of chromosome 9 to 22 that produces the BCR-ABL gene and subsequent BCR-ABL protein. This protein is a tyrosine kinase that enhances cellular proliferation and provides resistance against apoptosis. The mutant BCR-ABL is in the common myeloid progenitor cell and myeloblast, along with the subsequent white blood cell lines. Specifically, basophil, eosinophil, and neutrophil promyelocytes, which are produced at a high rate and spill over into the blood. Same story with basophil, eosinophil, and neutrophil myelocytes, metamyelocytes, and bands to a lesser degree. Why bands to a lesser degree? This is an unregulated cancer making immature cancerous cells. The sheer majority do not even reach the band stage of development. With few cells reaching the band stage of development, mature leukocytes are far and few between, leading to a functional leukopenia due to chronic myelogenous leukemia, a myelophasic process. Let me explain. A myelophasic process involves any condition that results in replacement of normal bone marrow with elements not capable of hematopoiesis. Here, cancerous chronic myelogenous leukemia cells with the BCR-ABL protein are literally taking over the normal bone marrow, pushing out normal stem cells, resulting in pancytopenia or low red blood cells, anemia, low platelets, thrombocytopenia, and low levels of functional white blood cells. This is called a functional leukopenia because the blood is filled with white blood cells. The white blood cell count is very high, but those are cancerous cells not capable of performing normal white blood cell duties. Hence, why it is called a functional leukopenia, even though chronic myelogenous leukemia is causing a false leukocytosis. Leukopenia is also caused by numerous immune-related disorders. Let me give you an example of an autoimmune and inherited immunodeficiency cause of leukopenia. Based on this rash that spares the nasolabial folds, what is your diagnosis, student doctor? Let's say that the patient was out in the sun and then developed this rash. What is it? This is the malar rash in a patient who has systemic lupus erythematosus. Whenever you see a malar rash, a butterfly rash, that spares the nasolabial folds, think lupus. You can see that the skin beside the nose, nasio, and labia lips is not affected. That is nasolabial sparing of those skin folds. This is a classic finding in the malar rash of someone with lupus. Now, let me ask you, what kind of lupus does this person have? Discoid lupus. Discoid lupus actually gave lupus its name as these skin findings can be seen on the arms, legs, and other regions of the body. And so people thought that a wolf came and bit people to give them these discoid findings. Lupus means wolf in Latin, and so you can see the relation of wolf bites, and so you know where the term discoid lupus comes from, and now you know why systemic lupus erythematosus is named as such. I really love medical history when it relates to stuff like that. It's interesting to know where these terms came from. Let me ask you a high-yield question. If we were to measure the complement levels in the blood of these two patients, would they be high or low? Low. A hallmark feature of lupus is low complement levels, which makes sense because lupus is an autoimmune disease that is using the immune system to wreak havoc on the body, and so the complement system complements the immune system and is depleted due to overusage in this autoimmune disease. Last question. What antibody is the initial test and has a high sensitivity for lupus? A positive ANA anti-nuclear antibody has 98% sensitivity for lupus. Overall, lupus is an autoimmune disease, so it produces autoantibodies against normal body cells. These autoantibodies can bind to white blood cells, red blood cells, and platelets, leading to destruction of all three cell lines, causing pancytopenia. When the antibody binds directly to its target, that is the white blood cell, red blood cell, or platelet, and mediates its destruction, what type of hypersensitivity reaction is this? A type 2 hypersensitivity reaction. Lupus also demonstrates type 3 hypersensitivity reactions, such as when immune complexes develop and deposit in the kidney to cause glomerulonephritis. In terms of an inherited immunodeficiency causing leukopenia, severe combined immunodeficiency, SCID, is a very high-yield example. It has several causes, such as from defective IL-2 receptors, a RAG mutation leading to defective VDJ recombination, or an adenosine deaminase deficiency. the most high yield cause to know, as it relates heavily to biochemistry and the purine salvage pathway pictured here. Highlighted is where adenosine deaminase acts within the purine salvage pathway, abbreviated ADA. You can also see that the image lists SCID for severe combined immunodeficiency. When adenosine deaminase is deficient, adenosine builds up, leading to more backups such that adenosine monophosphate builds up, increasing the pool of nucleic acids, and ultimately deoxyadenosine triphosphate. These backups provide negative feedback to ribonucleotide reductase, a key enzyme in DNA production. Ultimately, this leads to a decrease in DNA precursor production. Without enough DNA precursors, there is a decrease in white blood cell production, as white blood cells require a lot of DNA to be produced. Not only this, but accumulation of toxic purine degradation products also contribute to leukopenia. SCID can be recognized in newborn screenings that show a decrease of T cell receptor excision circles, Tregs, a chest X-ray demonstrating an absent thymic shadow due to the loss of T cells, and a lymph node biopsy showing absent germinal centers due to the loss of B cells. The last etiology we will cover are bone marrow etiologies, which center around aplastic anemia. A means without, and plasia means growth. So this is a type of bone marrow failure that results in absent growth of cells. Looking at this bone marrow biopsy, you can see there is an absence of purple nuclei. That is, the bone marrow is acellular, without cells, or hypocellular, with less cells than normal. The normal bone marrow filled with cells. Purple nuclei are usually everywhere in the bone marrow, has now been replaced by fat. All those white circles represent fat deposits, as the staining process physically removes fat and just leaves the outline of those spaces. This condition is called aplastic anemia, referring to a deficiency of red blood cells. However, look at that bone marrow biopsy. Do you really think platelets and white blood cells can be produced from it? No! The bone marrow is replaced with fat. It cannot produce red blood cells, platelets, or white blood cells. It is nothing but fatty bone marrow. And so, this condition should actually be called aplastic pancytopenia, as there is a loss of hematopoietic precursors to all three cell lines in the bone marrow. Causes then can be remembered by asking, what causes a loss of stem cells in the bone marrow? The cause can be idiopathic or unknown. However, research has shown an immune-mediated T-cell destruction of stem cells, further supported by the fact that patients respond to immunosuppressives such as cyclosporin and anti-thymocyte globulin, both of which decrease T-cell activity. Radiation has also been shown to lead to destruction of bone marrow stem cells. Infections, especially viral infections, have been shown to destroy stem cells. Acute hepatitis from Hep A, B, C, D, and E have all been related to developing aplastic anemia, aplastic pancytopenia. Parvovirus B19 is an interesting cause because it infects pre-erythroblasts by binding to P-antigen globoside. This usually causes an aplastic crisis, marked by anemia only. However, in those that are immunocompromised, aplastic anemia, which should be called aplastic pancytopenia, can occur with the virus affecting all three cell lines. Chemicals and drugs can also deplete bone marrow stem cells. Benzene exposure in the rubber industry is a classic example. Look for the person working in shoe assembly and repair as they work with rubber. Chemotherapy drugs are anticipated to cause aplastic anemia. Propylthiouracil, PTU, and methimazole can be used in the management of patients with hyperthyroidism and have been known to cause aplastic anemia, requiring routine monitoring of blood cell counts. Lastly, the most high-yield cause is an inherited form of aplastic anemia that is autosomal recessive or X-linked and is called Fanconi anemia. Again, a bad name for a condition that causes pancytopenia. It should be called Fanconi pancytopenia. Do not confuse this with Fanconi syndrome. That is a proximal tubule defect in the kidney. Fanconi was a busy person. Overall, in Fanconi anemia, there are defects in DNA repair enzymes, especially those involved in DNA cross-link repairs, predisposing patients to pancytopenia and an increased risk of cancer, as accumulated DNA mutations and cancer risk are synonymous. In a board question, look for other organ system involvement and physical deformities, such as cafe au lait spots, which look like spilt coffee on the skin, short stature, and deformed thumbs, a real clue for Fanconi anemia. Alright friends, it's time for a flash quiz. The question reads that a 50-year-old female patient with a history of Crohn's disease is being released from the hospital after a flare of symptoms that were treated with IV steroids. Previously, disease activity was controlled with adalimumab every 2 weeks. Therapy is escalated to now include azathioprine. A history and treatment of what condition may require extensive drug monitoring of this new therapy to avoid excessive leukopenia. A. Graves' disease. B. Gout. C. Type 1 diabetes. Or D. Type 2 diabetes. The correct answer is B. Gout. Gout can be prevented with febuxostat or allopurinol. These drugs work in the purine degradation pathway to inhibit xanthine oxidase to reduce uric acid levels and prevent gouty flares. Xanthine oxidase inhibition can raise azathioprine and its metabolite 6-mercaptopurine to toxic levels, leading to excessive leukopenia beyond the treatment effect. This biochemistry is so high yield, let's briefly cover it in more depth on the next slide. Keep in mind that azathioprine is converted by the body into 6-mercaptopurine. 6-mercaptopurine is converted by HGPRT into its active form thioinosinic acid, which inhibits multiple steps in purine metabolism, especially in purine salvage pathways pictured here. The arrow indicates HGPRT, hypoxanthine guanine phosphoryl transferase, the enzyme that activates 6-mercaptopurine into its active metabolite, thioinosinic acid. By relying on activation by HGPRT, a key enzyme in the purine salvage pathway, multiple steps in purine salvage are inhibited. Ultimately, this decreases the amount of purines available for DNA synthesis. To further place these drugs in context, here is the pathway for purine de novo synthesis from basic DNA building blocks recovered from the salvage pathway or from other molecules. I connected the arrows between the pathways to emphasize that HGPRT is needed to activate 6-mercaptopurine to its active form to inhibit both purine salvage and subsequently purine de novo synthesis pathways. Importantly, and this is very high yield, it is important to know that the active metabolite of 6-mercaptopurine, thioinosinic acid, is inactivated by xanthine oxidase. This makes sense based on the biochemistry we have covered. Looking back at the purine salvage pathway, you can see that purines can be salvaged by HGPRT or degraded by xanthine oxidase, abbreviated XO. Xanthine oxidase is a key enzyme in purine degradation, so it makes sense that 6-mercaptopurine and its purine analog thioinosinic acid is degraded by the key purine degradation enzyme xanthine oxidase. Therefore, xanthine oxidase inhibitors like allopurinol and febuxostat can lead to boosting of drug levels or bring them to toxic levels that cause excessive leukopenia beyond the intended treatment effect. All of this biochemistry is very high yield for test day. Thank you for sticking with me throughout this lecture. Here are a few key takeaways I want to make sure you know for test day. To understand leukopenia, you must understand terminology. Pancytopenia refers to anemia, thrombocytopenia, and leukopenia. Leukopenia is further subdivided into granulocytopenia, monocytopenia, and lymphopenia. Myelosuppression can lead to pancytopenia, with leukopenia mainly manifesting from granulocytopenia and monocytopenia. There are many causes of leukopenia, such as drugs. Glucocorticoids cause monocytopenia, eosinopenia, and lymphopenia while causing neutrophilia and an actual overall increase in the white blood cell count, a very high yield fact to know. Infections from viruses, fungi, bacteria, and parasites, neoplastic growth leading to myelofibrosis processes, bone marrow causes such as aplastic anemia, which should be called aplastic pancytopenia, and immune disorders that are inherited, such as severe combined immunodeficiency (SCID), and autoimmune causes, such as lupus. Friends, if you enjoyed the lecture, give it a big old thumbs up and leave a comment, even if it's just to say hello. And always, always, always remember, there's a great big beautiful tomorrow.